units, and you can see this is the pituitary fossa, and then the gland here, the pituitary fossa is here, the gland here is big, and it's eroding into the sinus here. So this is macroprolactinemia, macroadenoma, and secreting high prolactin, and this one needs to be treated easily with bromocriptine, dopamine agonist, and you will string, and then she will be very happy, the menstruals come back to normal. So as we said, high prolactin, the causes is quite high, 20%, and some of them have milk in their breast, some of them have eye disturbances because that's where the tract cuts, and some of them headache, prolactin more than 500, and the treatment is as outlined. So I'm going to talk about polycystic ovarian syndrome because this is quite a common disease that we see in our clinic. And it is a disease defined by three criteria. Number one is, of course, menses. We always talk about menses. This time, the menses doesn't come, or it comes every 2 months, or every 3 months, or 1 year is only twice. So this is anovulation, number one. So number two, they appear to have high androgens. It's as if they got more hair on the chin, they need to shave, or they got a lot of pimples. So, and they say, doctor, I don't look very beautiful because so many pimples. And when you do the ultrasound scan, you find that the ovaries have a lot of cysts. This is not the big cyst with the tumor. This one is this little cyst, less than 10 millimeters in size, but there are a lot of them. And also some secondary causes we have to exclude, androgen secreting tumors, especially if the hirsutism comes very fast, within 2 or 3 months, Cushing syndrome or congenital adrenal hyperplasia. So again, we just measure the hormones, and if the hormones show high testosterone, so that's the one causing the hair and the pimples. High luteinizing hormone, and also if they have high insulin, because this is the other player that causes PCOS to become bad, insulin resistance. But FSH in the normal range, estradiol in the normal range. So if you do the LH-FSH ratio, it's very high, more than 2 or 3. And Professor Iko will tell you that this is a characteristic of polycystic ovarian syndrome. So 2 out of 3 of these, we can diagnose polycystic ovarian syndrome. So maybe I just like to share a case for you, which is one of the worst cases I've seen of polycystic ovarian syndrome. In fact, she's from Indonesia. Her mother brought her to see me. This is an 18-year-old girl. Because she said, doctor, I'm so worried because my menses only comes once a year. And she said, I got hair everywhere. I got hair, not on my head, which I like, but I got hair on my forearms, on my legs, on my abdomen. I got mustache since I was young. And most importantly, I got dark patches, dark streaks on the neck, on the axilla, on the elbow. And the weight is slightly increased now. The height is 1.58 meters and the BMI is 27. What do you think are the dark patches in the groin and the back of the neck? Maybe I can show you and then you can we can decide what is this. I don't know whether you can see well, but this is the neck. These are little strips of black area. Yeah. And this is the axilla. And the axilla here, she's very fair, but you can see the dark patches, and these are the lines that, these are not the normal lines, but these are black, as if in the nigrans, in the pregnancy, you have the linear nigrans, that kind of black mark. And then in the groin, you can see the mark here as well. Yeah. And finally, she got the clitoris that's very big, clitoromegaly. So in fact, what she has is what we call acanthosis nigricans, a condition where the insulin is high, and when the insulin is high, it causes deposition of these melanomatic dark patches. The AMH is high at 50, LH is high, FSH is normal, testosterone is raised, the normal should be less than 2.9, she's 3. Sex hormone binding globulin is low because testosterone inhibits sex hormone binding globulin. Ovaries, you can see the typical many cysts there. So when I scan her, and you can see these are the ovaries, and you can see all the little cysts, like a pearl on a string on the surface of the enlarged ovary, and a very prominent theca, and this is characteristic of polycystic ovarian syndrome, what we call increased antral follicle count, all these small little cysts. So interestingly, in our cohort, when I work with Professor Iko, and we collect all the cases, and we measure the AMH. This is normal patients, 200 of them, and we do the cycles, short cycles, normal menstrual cycle, 25 to 34 days, and long menstrual cycles, and this is menstrual cycle length, and AMH, and we find that the longer the menstrual cycle length, the higher the AMH. And also, if we plot antral follicle count, the number of cysts, with the menstrual cycle length is the same, goes up like that. So this is quite interesting to us, that this is the first time anybody has described that antral at the anti-Mullerian hormone levels correlate with menstrual cycles. This is the first description. So what we found when we read the literature is that we think the AMH is the ovarian mediator for the human menstrual cycle. That if you have low AMH, your cycles are short. If high AMH, your menstrual cycles are long. So this is the antral follicle. The anti-Mullerian hormone, AMH, is secreted by the granulosa cells of the antral follicle. Only between do I have time? I've finished my time, I think. Okay, so I must finish quickly. So in the antral follicle, but anti-Mullerian hormone actually decreases as you grow older. So what happens is the anti-Mullerian hormone inhibits aromatase, inhibits estradiol, and then increase the length of the menstrual cycle. For each 14% increase in AMH, menstrual cycle length increased by 1 day. This is not my work. This is done by other investigators all over the world. So, and this is in interest the IVF people, yeah. So this is the paper by Brodin in 2008, long time ago. This is menstrual cycle length. This is cycle length short, less than 25, 26 to 27 day menses, and this is more than 34 days, right? And this is the pregnancy rate per stimulation, oocytes collected, FSH stimulation, pregnancy rate for frozen thaw cycle. Do you think pregnancy rate in these IVF cycles, more than 6,000, would be better with long menstrual cycles or short menstrual cycles? The answer is the longer menstrual cycles, the higher the pregnancy rate, all across. So whether it's pregnancy rate per stimulation start 20, 26, 29, 32, 36, 39. So the longer the menstrual cycle, the higher the pregnancy rate. So, I think oligomenorrhea and long menstrual cycles actually it's not a disease, you know. Because like for this case, right, she's a lecturer, she has seen me for the last 30 years. When she see me in 1996, menstrual cycles very long, and I gave her a bit of medicine, and then she got pregnant. And when I see her now, her menstrual cycle are already regular. So what happens is that in this PCOS subtype, where you got oligomenorrhea, the menses 35 to 45 days, the antral follicle count is high, AMH is high, testosterone is high. What will happen is that they get better as they grow older. And I think these are actually a normal continuum and resolve with age. So we shouldn't tell these people that they are sick, they won't get babies and all that, because it's very bad for the morale. So in my last slide, so I think that if you have just polycystic ovarian syndrome and high AMH and your menstrual cycles is long, but every 35, 45 days, you shouldn't call it abnormal. The AMH is high, testosterone is high, but this will resolve with age. And especially if you're young, you're teenagers, you will get this. But when you grow older, you will resolve, menstrual cycles become normal, and you get pregnant. But when you have something called insulin resistant or metabolic syndrome or something else, then the testosterone becomes too high and you get amenorrhea. So once a year, one period or no period, then that's the disease. Yeah. So that is the treatment for PCOS. You have this disease, and the hyperplasia, exercise, ovulation, induction if necessary, and this is what I just said. So I think I better stop here. So thank you very much. I've exceeded my time.
Thank you. Thank you. because nowadays our PCOS patient basically getting younger, and most of our PCOS patient nowadays is coming from the teenagers. So what are you going to address to this group of PCOS patients? Should they start the hormonal treatment soon, or should they try to change their lifestyle until certain time, and then if it doesn't work, then we can start the hormonal treatment? So what was your experience in Singapore?
I think Professor Kanadi has brought a very important question because they are younger, and I think people are healthier. And the ovaries are big because some people are taller. Now our people are getting taller because they got good food. So I think the ovaries also become bigger. And they have also more antral follicles. If there are more antral follicles, they secrete more AMH. And the more AMH, the menstrual cycles become longer. And when you do the ultrasound, you see a lot of follicles, and you measure testosterone is high. So you tend to label these people as PCOS. But I think it's important not to label patients with PCOS when they are a teenager, because as they develop, their menstrual cycles become more normal, and then the testosterone will go down, and I think the fertility will be quite high. Of course, if they maintain their weight, it'll be better, because the insulin and insulin resistance will make the testosterone effect worse. But the main thing is, I don't think they should worry, because it's something that will resolve with age. Yeah.
Thank you. Yes, Dr. Iko, please.
Yeah, thank you, Professor Yong, for a very inspiring lecture. So very interesting that the longer menstrual cycle, the patient is suffering subfertility, but the success rate of pregnancy even higher. Yeah, we know that it is related to AMH because the number of the egg is increased. But what is your opinion if we try to correlate the quality of oocyte itself in PCOS patients? Because many studies prove that there is some detrimental effect PCOS to quality of oocyte. And then the second question, how about the impact of nutrition in order to improving the symptoms of the PCOS? Thank you.
Professor Iko also asked very difficult questions, so I don't know whether I can answer, but I will try. I think the first question is related to the menstrual cycle length and the quality of oocyte. But the data I just presented shows that actually the quality of oocyte is not bad in this group of people. But I forgot to mention that actually this group of people have menstrual cycles more than 35 days, but less than 50 days. So they are between 35 to 50 days, but still coming regularly. And in this group of people, actually the oocyte quality is very good, because you can see in terms of oocyte collected, oocytes per fertilization, oocytes per embryo transfer, all of them are better for the 35 to 50-day menstrual cycle length compared to the other groups. So that's one. But if your menses is more than 2 months or 1 or 2 years, I think that will be the one where the oocyte quality will be bad. But this is just my thinking. I have no evidence yet. I'd like to get your views as well, Professor Budi.
Okay, thank you. And then the second question about the nutrition, I think.
New nutrition, I have no idea, except that if you control your weight and you exercise and you have muscle, because the muscle will reduce the insulin resistance. And I think if you have good metabolism, then the polycystic ovarian syndrome will become better. So many studies have shown that insulin resistance, obesity is a risk factor to make PCOS worse. So if you have good nutrition and good exercise, and if your body weight is normal and you don't have insulin resistance, that can only be helpful for PCOS, I think.
Yeah, I think regarding the quality of oocyte, also I agree with you. Actually, let's say the menstrual cycle between 35 to 50 days, and also there's a ceiling of AMH level. Because if AMH level is too high, it will determine to the quality of oocyte. So the longer of menstrual cycle, the higher of AMH. But we don't know actually what is the the above of the ceiling.
The ceiling,
Yeah,
huh?
the ceiling is very important.
Yeah.
Thank you.
Maybe we should do that study, get more cases and understand the ceiling.
Okay, do we still have one question from the floor for Professor Yong? I think I would like to ask you a last question regarding to the AMH level, because it seems like you really values the AMH assessment on different PCOS subgroup. So what do you think about to use AMH as an indicator for treatment? Because nowadays we still do not really exactly sure how to reduce the AMH level. So how important is the AMH level for indicator of treatment?
Yeah, I think AMH is getting more and more focused as a very important hormone in PCOS and also in follicle development. And there has been some move towards replacing the ultrasound scan measurement of antral follicles, and which, as you know, is very difficult and you've got to count. And now the instruments are more and more sensitive, so you count more and more follicles. Now they say 12 less than 10, but if you use the Voluson E8, you will count 25, 30, and these are perfectly normal people, you and I know. So maybe the AMH is a better marker because it doesn't depend on the sensitivity of the instrument. But the problem with AMH is the assay. As you know, because there are so many different assays and standardization between different laboratories is still a problem. I think if you meet the challenge, if the AMH assay can be standardized properly, then AMH may replace ultrasound antral follicle count, and actually it may be a good global marker to diagnose PCOS, in terms of hormone serology. But that's just my opinion. Yeah.
Okay, thank you very much, Professor. We